Okay, got it. We are now live with Carlos Yumaguano in Yemen.
John, do you see me?
Yeah, I see the screen.
Just a moment, because I know I'm not seeing the screen. Okay.
Okay, you're screen sharing, but you're screening another screen. Okay.
Yeah. Just a moment.
Okay. We're learning this tech, folks.
Okay.
شوف في عنده يعني في awake anatomy protocol for brain gliomas اول محاضره كمبيوتر ان شاء الله الحصه الجايه awake anatomy.
It's impossible for me, but
You can't open the PowerPoint, Carlos.
yeah. I tried to do that.
Yeah, open the PowerPoint first, and then you come back to the screen share.
No, I have the whole.
There you go. You got it. You got it. Beautiful.
Okay.
All set, Carlos.
Is this okay?
Yes.
Okay. Good morning. Thank you very much for your invitation for this conference. Today we will speak about topics about spinal trauma in elderly. We will speak about the management of vertebral body compression fractures in the elderly patients. We know that in the spinal in the spinal trauma management, we can have a clinical assessment about what kind of neurological deficits or neurological change have the patient. And we speak about the diagnosis, what about the clinical evaluation and radiologic assessment, such as needed to do an X-ray, what was the paper in a conventional X-ray, functional X-ray, and some kind of specifics rays. And what's about the spine CT, the paper with a three-dimensional CT, and sagittal or coronal view. What's about the reading of the spine MRI? And we can analyze about the treatment of this change in the vertebral body. If we need a conservative treatment, such as using as orthosis, or maybe the patient just need a rehabilitation, or we have to do a surgical treatment. It's dependent, it's urgent, deferred, or programmable surgical treatment. We can do a follow-up patient after the acute stage treatment, such as maybe he needs a monitoring and a control for the patient at several times, or need to continue with the rehabilitation. What about the classification of the fracture? We can use the classification for our spine, which system analyze about the anterior column and posterior column. We can have which kind or which types of fracture we have: type A, type B, type C, and each of them with the management specifically. For the neurological evaluation, we can use a Baccaro scale, or maybe a Frankel scales. In the spinal trauma, we can have use or a macro classification. The type of fractures which important is an axial compression, and we can have A1, A2, A3 types of fracture, but in all times they are affected just the anterior column of the vertebra. Type B fracture essentially is by the placement in a sagittal plane. In these types of fractures, we can have an effect of the anterior and posterior column of the vertebra. In the type C, we can have a displacement of the in the coronal plane with a serious affecting of the anterior, medial, and posterior column of the vertebra. In a clinical assessment, the most commonly used scale at the international level for assessing the extent of or completeness of the spinal cord injury is the ACE. It's an American Spinal Injury Association standards for neurological classification. This scale classifies spinal cord injury according to the 5 grades determined by the absence or presence of motor and sensory function. With the Frankel classification, we can have a Frankel A, where it's an absence of motor and sensory function. The type V, there is a sensation present, but completely absent of motor function. In a C type, sensation is present, motor function is present, but it's not functional. It's a grade of paralysis 2 per 3 per 5. Type D, the sensation present, motor function are present, and may be useful because this is in a grade 4 per 5. And type E of Frankel, it's a normal function, motor and sensory function. In this kind, we can see the distribution of the motor, neurologic innervation, and the sensory function too. For this conference, the important thing is I will speak about the treatment or management of fractures in the elderly patients. Fracture of the vertebral body due to wetting or compression in elderly patients are frequent and affect approximately 20–40% of the population. Usually affect the thoracic and lumbar region and not always associated with neurological deficits. The relative risk of fracture after an initial fracture is about 4.4 to 5.4. After a vertebral fracture, the risk of a new fracture per year is approximately 19.2%, and the cumulative incidence in 10 years is approximately 70%. In these pictures, you can see the normal structure of bone and down the osteoporotic bone, with a important diminution of the mineralization of the vertebral bone. We can have different causes such as osteoporosis, maybe a pathological fracture, maybe tumor, and just a traumatic fracture, non-osteoporotic, type A and type B of Mager. What's the objective? It is primordial to avoid a neurological injury in those patients who remain neurologically intact after trauma, using techniques of grit or release or aggressiveness. The solution should be pain relief, restoring anatomy, early diagnosis and treatment, or an adequate aid for geriatric patients given the frequent fragility of their condition and the presence of multipathology. What about the symptomatology? A vertebral fracture produces localized edema and there is often pain. In the spine, edema and lack of alignment can irritate the adjacent tissue and nerve elements. A damaged vertebra is sufficient to alter the alignment of the spine, and the distribution of the weight in it, which could cause other fractures. How to assess these kinds of fractures? We can do it at a correct physical examination. We valorate the pain. We can use for this a brain pain inventory scale or visual analogy scale for the evaluation. What's about the neurological symptoms, sensory function, motor function, sphincter function. We can use a Franklin scale to do a correct neurological deficits examination. In imaging or radiological imaging studies, we can use a simple X-ray to define the stability of the vertebra. We can do it in a CT scan. We now must determine if the presence or not a bone fragment. What about an adjacent segment? Maybe we can use a spine MRI, a T1, T2, or steer sequence. At this point, we can discuss about if this type of studies is urgent or maybe deferred for any time. We can do in a bone scintigraphy to determine if the patient had or not osteoporosis. What about the treatment? Disease results are obtained as soon as a fracture is treated. Kyphosis, deformity, and progressive bone weakness increase the risk of further fractures. We can do it on a conservative treatment, open surgical treatment, or vertebral reinforcement techniques. A conservative treatment is what's about that? Maybe the patient needs a bed rest, but we would increase the bone loss. We can use different analgesics such as narcotic analgesics could fail. And what about the adverse effects for H drugs? Or we can use orthosis. They may do it at a long-term functional improvement. Or maybe we need to do a surgical treatment when there is a neurological deficit. If we need to decompress neural structures and provide stability to the fractured vertebra. And what is the situation in different cases in the elderly patients which frequently had an osteoporosis? What about the results in this kind of patients? Or maybe you can use a vertebral reinforcement techniques such as a vertebroplasty described by Dermot and Galibert in 1986, or do it on a kyphoplasty described by Riley in 1998. And so we can speak about the needing or kyphoplasty or vertebroplasty to do some situation. We must know that kyphoplasty or vertebroplasty techniques, it's a minimal invasive procedure that can repair the wedging or compression vertebral fracture. Both the treatment had results at specific to each patient. Early and effective treatment can reduce the consequence of spinal fractures, especially those associated with other treatments such as prolonged bed rest or the use of H analgesics. What's about the benefits of this kind of techniques? It restores the height of the vertebral body. It restores proper alignment of the spine, significant and lasting decrease in back pain, significant and lasting improvement of mobility, significant and lasting improvement of the quality of life for the patient, significant improvements in activities of daily life, decrease in the number of days and months that the patient remains in bed due to back pain. And the important thing that's significant Unless it decrease in the number of days a month that the pain interferes with the daily activities, such as walking, hobbies, or work for the patient. Yeah, we have a kyphoplasty techniques, and we can do it all kinds of solutions for different fractures in the patient. But all the techniques, or all the surgery techniques, maybe open, maybe percutant, maybe minimal invasive therapies, had different risks. The frequency of complications in kyphoplasty or vertebrates is very low. Maybe a serious adverse events can occur, some of which can be fatal, like a heart attack, cardiac arrest, stroke, or embolism. And maybe other complications such as infection, cement leakage, which can affect the surrounding tissue, or spinal cord compression, or nerve elements compression. The indications for these kinds or techniques are in osteoporotic fractures, in pathological fractures, where actual vertebral pain due to a pathological compression fractures, such as tumor, non-pathological fractures, pure traumatic, if we have the following requirements: non-osteoporotic fractures types A and B of Magel, posterior large ligament intact, early intervention in the first 7 days after fracture, no signs of infection. It may be ideal in multiple myeloma, where bone quality limits surgical options, limited in patients with neurological deficit, and or with involvement of the epidural space. It can be combined with radiosurgery in the treatment of vertebral pain by pathological vertebral collapse. What about the contraindications? Absolute contraindication for kyphoplasty or vertebroplasty are important involvement of the medullary canal by epidural tumor, bone fragment, or discus, impossibility to determine the painful segment of or when the patient is very symptomatic, inoperability, if the patient has some medical problems that is absolutely contraindicated to do, and some kinds of anesthesiology techniques. And the relative contraindications are deformity of the vertebral body, such as flat vertebra, rupture of the posterior wall of the vertebral body. I will show some cases that do it. For example, the first clinical case, we have a 74 years old patient, a pathological antecedents as diabetes. She had a severe and incapacitated dorsal lumbar pain for months of evolution. At the physical examination, no health paralysis, maintained osteotendinous reflexes, antalgic gait, and posture. What kind of stats we are doing? X-rays, MRI. Well, the diagnosis was the fracture of the 12 thoracic vertebra, lumbar 1 and lumbar 2 vertebral body fracture. We do it at a percutant kyphoplasty, and the patient after 3 days was discharged to home. In the second clinical case, an 84 years old patient, pathological antecedents such as arterial hypertension, dementia, and the symptoms about intense and incapacitating high lumbar pain of months of evolution. At physical examination, limited activities of daily living, wheelchair bound, little movement, decreased osteotendinous reflex, no pyramidalism. We do in this case again X-ray, MRI studies, and we determined the fracture of L1 lumbar 1. We treated with kyphoplasty. After 2 days, the patient was discharged to the home. Third case is a 76 years old patient with arterial hypertension. Symptoms was about severe and invalidating high back pain. Does not improve to conservative treatment. In a physical examination, no paralysis, maintained osteotendinous reflexes, no pyramidalism, antalgic march and posture. Studies were doing and X-ray, MRI, percutan, or kyphoplasty. In this picture, you can see 3 months after surgery. After 2 days, the patient had marked relief of the pain. After 2 days, they were discharged to the home. In the last cases, is an 83 years old patient with benign prostatic hypertrophy, splenomegaly, and lymphoproliferative syndrome. After fall, the patient had a severe dorsolumbar pain, which does not improve to any treatments. And a physical examination, for example, they have no paralysis, decreased osteotendinous reflex, no pyramidalism, march and posture limited, almost entered. I have do it on a CT, on a simple X-ray, CT, MRI, and the patient had a fracture of vertebral body 12, thoracic 12, lumbar 1, 2, and 3. We are doing a kyphoplasty of thoracic 12, lumbar 1, lumbar 2, and lumbar 3. The patient had a marked pain relief, and they have a marked improve of their gait, and they have discharged from the hospital after 4 days of treatment. So, at a kyphoplasty, vertebroplasty, we can do it with some kinds of materials like a kypho with cement, the Spain check, when some kinds of metallic prosthesis, or with silicone. The silicone is used generally in young patients. What about the drugs that they will be needed in patients? Calcium, vitamin D, strontium, ranelate, teriparatide, hydronate, such should be some kinds of pharmacological treatments parallel or after kyphoplasty. So this is the management of some kinds of fractures in patients, in elderly patients, where it's frequent the presence of osteoporotic change. So thank you very much for your attention.
Thank you so much, Mr. Carlos. Actually, we can open the session for discussion. If anybody has any questions, يا دكتور نصر تعال هنا طبعا ولا استلم هذا وخليه عندك. تعال حيسمعك بالميكروفون والدكتور حيصورك بالتليفون. محمد شمس يصورك. اعطيه محمد. What about other modalities such as that other than psychoplasty and محمد الرجال مش حيسمع حاجة. مش حيسمع حاجة عنده. نص أكون size short question تقدر ترجمه.
Ishmael, we can't hear the question.
Actually, this is me too. كم نصر here? كم نصر?
Could we have Mohammed use the camera moving like we did yesterday?
Okay, Dr. Nasser, we're going to repeat the question slowly and precisely.
Okay, very good. Thank you.
What about the type C McGreal fracture in osteoporotic patient? And what other modalities of treatment other than vertebroplasty and kyphoplasty? What the other rescue procedures?
You could, you could,
Thank you very much. Thank you very much for the question. During the conference, I said clearly that kyphoplasty or vertebroplasty we use just in type 1A, 1A2, or maybe A3 fractures, osteoporotic fracture in the elderly, or maybe in matter R on B. But in the C type of fractures, when we have an effect in the anterior, medial, and posterior column of the vertebra, when where the posterior large ligament is disrupted, where the posterior wall of the vertebral body is disrupted. These kinds of techniques we cannot use because this the cement that we are using for these kinds of techniques may be leakage and maybe compress the medullary elements in the spinal canal. In these kinds of osteoporotic fractures type C, maybe the important thing is to have an orthosis alignment and maybe do it or adjuvant it with some kinds of pharmacologic treatment, such as a forsteo, such as protelos, that will be help in the calcification. But because it's maybe difficult to do an open surgery treatment, because in osteoporotic bones, it will be not a good result.
okay, thank you so much. Actually, we are on time, and we can go for the next speaker. And if you are allowed, Mr. John, I have to welcome Dr. Mohammed Zahir and sending him a big greeting from heart, from Sana'a, to the Yemeni Neurosurgery Ambassador in New York. Dr. Mohammed, very glad to see you again, virtually at least. And everybody, I think you are famous here in Sana'a, and everybody knows you. So just we are welcoming you, and we are waiting for your great presentation. So go ahead.
Hello, Prof. Ismail. Thanks a lot for this welcoming. Really, I miss you. God knows only how much I miss you all. Really.
Okay, go on.
Okay.
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 1 minute.
Okay.
Yes. Okay. Yes. Muhammad, yes.
I have.
John.
Yes,
we
he's
are
working.
waiting for Muhammad.
Yeah, he's working on it.
Okay, Muhammad, go on.
1 minute. It's some technical issue.
Yeah, it's okay. Great.
Yes. Perfect.
Hello.
Perfect.
Yeah. Hello, everybody. I'll try to make a very short lecture. It is about wartime neurotrauma highlights of management. It will be some easy digest, only 10 slides. I hope you will enjoy it. First of all, I want to state that this lecture is in the memory of Dr. Thomas Kibinski. I think most of you know him from Facebook. He was our friend who died unfortunately died last month. We will always remember him with feeling of glory and honor. I take this statement from his Facebook page, die with memories, not dreams. And Thomas will be always a great memory for us. Also, I want to express my deepest gratitude to Prof. Ismail Kipsi and Dr. John Bennett for their tremendous effort. Also for doctors, all of my teachers in Yemen, and all our fellow neurosurgeons and residents. So first, this is a nice quote by Hippocrates. He who wishes to be a surgeon must first go to war, because in war you learn the surgery by its extremist, by the cases, by the stress, by everything. So, history of war trauma, it goes back since the beginning of history, like from the beginning of civilization. Over the years, over the centuries, there was a development of evolution of the weapons used, of the variety of the weapons used, that usually causes more devastating injuries that we encounter those days. So what makes the difference between war versus non-war injuries? First, the transport and triage are different. That means, in non-war injuries, usually there is some sort of even a medic or an ambulance taking the victim from site of injury to the hospital. So there was some sort of proper management, proper priority management on the way to transport. While in war, usually the one who gets the patient to the hospital is a fellow citizen or a fellow combat soldier. It's like this. Second is the differences in radiology. Usually the war cases, the war injuries are devastating multiple injuries. So you will have an extreme radiology, and usually you might need a full body scan, as there is usually penetrating shell injuries everywhere. Third, most commonly are penetrating injuries with blast injury is the most common cause. So again, while in non-traumatic and non-war injuries, usually it is a blunt trauma. In war injuries, usually there is a penetrating wound, and most commonly it is most common cause of war injuries is blast injury, either like self-made, homemade, or some kind of advanced weapons. Usually there is a pole trauma, and usually you have to deal with multi-system injured patient. Also, there was associated burns are more common. Burns, hyperthermia versus chemical burns. Serious hemorrhage that might cause a life-threatening condition is more encountered with war injuries. Challenges in the proper assessment of neural injury in the acute setting. Also, the challenges arise as when you have masses like what we had in Yemen. You suddenly have like 200 patients coming from all multiple injured. All this cause a stress chaos in the emergency department, and usually it is more challenging than words can explain. Also, usually when there is brain injury, you will notice a complex craniofacial injuries. These are oftenly seen. Secondary brain injury is a more prone complication. This because of two things: the hypoxia and the hypotension, which is usually a complication of another injuries that accompany the primary brain injury. Usually, to deal best with such patients, planning and multiple team coordination is the key of management of such cases. the traumatic brain injury in the setting of severely multiple organ injury. Major extracranial injuries in patients with severe TBI, it occurs in up to 40% of the patients. Usually, such patients are such victims are in need for rapid clinical evaluation, resuscitation, and even immediate invasive intervention for some, especially when there is hypotension or ongoing bleeding that is not responsive to primary resuscitation. What makes more challenging is the chaotic, stressful situation, plus the complexity of the nature of injuries. These are considered the major and more challenging. Again, team-based work and proper frequent communication between involved specialties is crucial. So, initial evaluation as a trauma center, rules and duties. Who should do that? Who should do the initial evaluation at the trauma center? I'm not talking about patients outside the hospital. I'm talking about after receiving of the patient in the emergency department. Usually, the American College of Surgeons have made some guidelines regarding this. Usually, the trauma surgery team conducts the initial resuscitation. The trauma surgery team is the initial sponsor for the resuscitation of multiple trauma patients in war. All level 1 and trauma centers should have a neurosurgery team readily available to participate in the assessment of patient if necessary. Also, there is another rule that neurosurgeons should be physically present in the emergency department within 30 minutes for every multiple injured patients. The source I wrote here, the reference. I will share the reference or the references for all of this lecture with you after the lecture. Okay, what are the priorities in the initial resuscitation? We usually follow the Advanced Trauma Life Support Manual, the ABCDs. Initial evaluation and management is done promptly with an emphasis on an orderly completion of primary and secondary surveys, along with indicating imaging studies. You usually aim, when there is hypertension, aim for systolic blood pressure 90 or more. The aim of proper resuscitation is to avoid secondary brain insult by hypoperfusion or hypoxia. You should know that we know all when we are dealing with a multiple trauma patient in the setting of the ABC, even it is ABC, we usually do the three of those together, like simultaneously as often as possible. Okay, thoraco-abdominal hemorrhage via brain CT scan. This is some challenge when deciding when to do a brain CT scan, when there is indication for brain CT scan in a multiple injured patient. The most important determinant is response to resuscitation in the hypotensive patient. If the patient is hypotensive, you either have a hypotensive patient or not. If it is not hypotensive patient, usually you go with brain CT if it is indicated. If it is a hypotensive patient, you are going with three categories. You resuscitate. If there is proper response, you do a brain CT. If there is a response that is transient, like while you are resuscitating and assessing the patient in the trauma triage or in the emergency, the patient develops a sudden drop in blood pressure. Those patients should go directly to operating room, as usually as the most common cause for this is an ongoing hemorrhage that need to be treated. Non-responders also should go directly to operating room. Okay. Low GCS and lateralizing findings argue more favor in CT scan of the head. You should know that some limitation of the Glasgow Coma score is that you might have a low Glasgow Coma score, but after resuscitation, the patient become better. Also, you might have a low Glasgow Coma score that is not related to something you can do operation for, like you have ischemia, brain ischemia, or something like that. Retrospective reviews have showed that in hypotensive trauma patients, the need for urgent laparotomy, thoracotomy for hemorrhage control is 10 times higher than the need for urgent craniotomy. I state this reference because even with this general, let's say general guideline, sometimes you found yourself in the process of a multi-team decision that in certain cases you might find yourself doing another decision. Usually this is, although there is a guideline, this is some flexibility with each case. Like each case is a special case. So priority of procedure, which is first. So if I have a patient with head injury and I have patient with like orthopedic injury or abdominal injury or thoracic injury, a certain way of risk of timing of non-head injury trauma should be kept in mind. Like there is risk for timing of I'm not talking now about the head injury. If the patient head injury is not needing operation, what should do about other injuries? Generally, it is usually the complication when there is some orthopedic injuries that does not need an immediate intervention, that is not life-threatening. So the problem with doing operation for such patients when there is a head injury that does not need operation is that early intervention may cause the susceptibility of the patient for hypotension and hypoxia. So there will be a secondary head injury, a secondary brain injury. Delaying the surgery too much can lead to increased rates of other complications, either related to the fractures itself or related to pulmonary complications like pneumonia and acute respiratory distress syndrome. Also, the decision should be made by proper communication between the trauma, surgical, and neurosurgical and anesthesia teams. This is essential as usually it is a complex decision. It should not be taken like individually. As a general rule, in unresponsive hypertension, as we mentioned before, control of hemorrhage precedes the cranial pathology management. In other cases, priority goes to head injury management. So if there is life-threatening hemorrhage, control of hemorrhage precedes the cranial pathology management. If there is not, the cranial pathology is the priority. Orthopedic injuries should be treated as safely as possible. A discussion between the anesthesiology and orthopedic versus the neurosurgeon should be conducted before orthosurgery, because usually orthosurgeries carry the risk of hypoxia and the hypotension due to bleeding and due to hyper, also to that may cause brain edema by more than need resuscitation or a huge resuscitation by fluids. So finally, in operative room positioning, when there is no clarity of the situation of the cervical spine, special care should be taken to the cervical spine, avoiding hyperflexion, hyperextension. Try to keep the cervical spine in neutral position. Also aim for adequate access to all teams. So when you do a position, you aim for adequate access to you as a neurosurgeon, to the orthopedic if there is orthopedic, to the general surgeon if it is a general surgeon, and also to anesthesia for the tube essentially, and for the IV lines. Okay, position should be decided and planned before draping and sterilizing to minimize any further repositioning of the patient, and to decrease the infection rates. For most laparotomies, supine is inadequate for both cranial and abdominal procedures. The laparotomies usually is nothing to debate about. Thoracotomy is a more challenging due to lateral position implementing, which make a more challenge for the neurosurgeon. A study by Hernandez found that 82% of general surgeons and 100% of neurosurgeons found a hybrid craniotomy laparotomy position acceptable for simultaneous procedures. Thanks a lot. I hope that was some easy lecture, not to put more stress on you. I think this is the last lecture. Thanks a lot again. Have a good day.
Thank you, Dr. Muhammad. Your lecture was the last but not the least, and it was very valuable. And I think we are just surviving the war stress, and it is a lecture with a point. Anyway, I'm just opening the session for discussion. If any of the colleagues or has any remarks, comments, questions, or anything like this, so Muhammad Zahar is ready to interact. So, any questions? Who? Sorry, Dr. It will be kind if you just come here.
I would take the mic and say hi to everyone in this room.
Welcome. Okay, start. Sorry.
Good morning. Thank you for your presentation.
Thanks a lot.
I don't have a question, but this is good viewpoint in this moment in Yemen. For example, I shouting too much with a student, with general doctor in my hospital, because many times is frequently receive the patient with cranial trauma, spinal trauma, and send the patient for do CT scan in the MAR and not take the primary measure. For example, no cover the wound, no stitch, and sometimes the patient died for coma, not for the cranial trauma, not for the spinal trauma. This is good viewpoint for medical college in Yemen. Thank you very much.
Thanks a lot. Thanks a lot.
Other questions? Who, Doctor, please? Just come.
Dr. Hamjali, Radiation and Food Center. عندي ملاحظة notice. I want, please, in the future, to speak about surgery of the brain tumor, I mean.
Okay.
And other treatment. Thank you.
Well, welcome. Other questions? No more questions. Okay. Sir John, we are going just to finish the session. It was a meeting online for us. It was the first experience to speak and to interact internationally, globally, with a fair intercontinental share. Thank you so much. I'm presenting my greeting and regards for Mr. John for his valuable and kind support and kind help. Thank you, Dr. Muhammad, and thank you for all the guests. It was great to have you again. Enjoy your time in New York. And Mr. Mia and Mr. John, I think it's your sleep time, so you can go and have a good dreams. Thank you so much for all of you. Have a nice day, and now we are going to switch to our local program. Okay, Mr. John?
Thank you very much. And remember, the Yemen neurosurgical community is not alone. You have neurosurgeons all over the world that want to interact with you.
We are so glad to have you inside of our society, and your great support was the cornerstone for the success of our conference, and everybody is grateful for your interpretation and your participation. Thank you so much. My heart feeling is so warm, and I'm arming you. Thank you so much. Have a good time, and we should keep in touch. Neurosurgery is awesome, and we should enjoy the moment.
Thank you very much.
Thank you so much, and have a good day.
Good night.
Bye-bye.
Bye-bye.
Good night. Good night.